Hello everyone, I'm Lynley Bilby and I manage the program called Blood Matters in Victoria, Australia. The program aims to support and enhance best practice in patient blood management and the stewardship of blood and blood products for improved patient outcomes. I also have the privilege of chairing the International Society of Blood Transfusion Practitioner Group. In this podcast and the next podcast, we're going to be talking about patient blood management, which we're going to abbreviate to PBM. PBM is a widely established international initiative with a multidisciplinary approach to reduce transfusion. There are a wide range of strategies designed to improve patient outcomes by managing and preserving the patient's own blood. As there are many aspects to PBM, today we're going to explore strategies such as preventing and reducing iatrogenic anemia and promoting the use of single-unit transfusion where it's actually safe to do so. Both of these low resource strategies could be introduced without having a dedicated PBM program. In our next podcast, we're actually going to highlight some PBM programs that are in place in different countries to give you an idea of how they work. The principles and benefits of PBM are well documented in the literature. PBM or activities that support PBM are one of the many activities that a transfusion practitioner may undertake as part of their role. If you're not sure what a transfusion practitioner is, you can go back to our very first podcast, which is What is a Transfusion Practitioner? Now, we're very fortunate to be able to bring you these podcasts with the support from the International Society of Blood Transfusion, which is known as ISBT. ISBT is a global community of professionals sharing knowledge to enhance transfusion practice and blood management. The Society does this by providing opportunities for advancing knowledge and education and by advocacy for the welfare of blood donors and patients. ISBT has many working groups that focus on specific topics or areas of practice, and the Transfusion Practitioner Group is one of these. So now we're going to meet our guests for today. So first off, I'm going to ask Rachel to introduce herself.
Thanks, Lily. Hi, I'm Rachel Moss. I'm a blood transfusion practitioner and I work at Great Ormond Street Hospital for Children, which is based in London in the United Kingdom.
Thanks, Rachel. Now, Jana, could you introduce yourself, please?
Yes, thank you. I am Jana. I am from Belgium. I work for the health authorities. We are working around blood transfusion and patient blood management. And I'm also working part-time as a transfusion practitioner in the University Hospital of Brussels.
Thanks, Jana. Louise.
Hi, everyone. I am the Patient Blood Management Clinical Nurse Consultant, ATP at Liverpool Hospital, which is located in southwestern Sydney, Australia.
Thanks, Louise. And Claire.
Hi, my name is Claire O'Reilly. I am the Transfusion Safety Nurse Clinician for British Columbia's Children's and Women's Hospital, which is located in Vancouver, BC.
Thanks, Claire. Now, Louise, can you tell the listeners a bit more about PBM and why is it important?
Thanks, Lindley. Listeners would have learnt from our previous podcasts that transfusion carries risks. So to reduce risks, it is vital that anyone who participates in the transfusion process know that we should only give transfusions when they are appropriate. There may be alternatives that would be better for the patient without having a transfusion. PBM is an evidence-based, integrated, multidisciplinary approach to effectively manage and conserve the patient's own blood, thus reducing unnecessary exposure to transfusion. As a process, PBM is much more involved than simply prescribing a transfusion or not. PBM has the patient as the central focus to improve their outcomes and to include them in the process. Literature describes 3 pillars of PBM, which include 1, optimizing the patient's own blood, 2, minimizing blood loss, and 3, optimizing a patient's physiological tolerance of anemia. PBM has a long history with much of the early work undertaken in America and Canada to reduce blood loss in surgery. Practices to reduce transfusion or offer alternatives to transfusion are increasingly embraced internationally as literature has been published demonstrating the risks and other consequences associated with transfusion. TPs in this podcast today have done audits that demonstrate that we have areas where we can improve the appropriateness of transfusion by looking at the patient to optimize their own blood to reduce the need of some transfusions. We'll touch on this more in our next podcast, where we'll look more closely at anemia management processes.
Thanks, Louise. Now, Claire, can you tell us how TPs are involved with PBM?
Yes, thanks, Lynley. Thanks, Louise. So the TP plays a vital role in helping to establish and embed PBM practices that improve patient outcomes. A paper published in 2018 in Transfusion Medicine by Bilby and Moss outlines the importance of the TP role to embed patient blood management into practice. Consistent with healthcare advances to become patient-centered and involve patients in the decision-making process, the TP role has also evolved to include patient blood management activities and practices. By emphasizing the patient's needs and the impact of transfusion has on them. A multidisciplinary team approach is required to drive PBM. As discussed in previous podcasts, the TP is a critical link within the multidisciplinary team, acting as an enabler by engaging all team members, including patients. TPs pull together resources, provide education, undertake reviews, collect data, and evaluate outcomes. And as such, they can be a driving force for change. Other ways the TPs support patient blood management includes, but are not limited to, reducing practices that lead to iatrogenic anemia, promoting appropriate transfusion practices in line with guidelines that include single unit transfusion, promoting tolerance of anemia and the use of electronic decision-making and prescribing tools, and implementing preoperative anemia management and pathways or anemia clinics, which we will discuss in our next podcast.
Thank you, Claire. There are certainly many ways TPs can be involved and support PBM. So, Rachel, can you tell us what is iatrogenic anemia and why is it important that we prevent it or reduce it?
Good question, and one that gets asked quite a lot, because iatrogenic isn't a word that's well understood, and iatrogenic just means medically induced, and anemia we know. And what we're focusing on here is where it occurs as a point of blood loss due to repeated blood sampling, so diagnostic testing. And it'd be really interesting, and this is the thing about podcasts, because we're not talking to people live, just how many of the people who listen to us even think about the volume of blood that we take from patients, because those mils, they really do add up quickly. And we know that the volume of blood taken for lab monitoring during hospitalization is a real contributing factor to the iatrogenic anemia. And especially in long stay ICU patients and children, as you can imagine. So we looked at some of the studies, and we know that blood loss in critically ill patients has a huge impact by iatrogenic anemia. And in 2002, a European study in ICU reported a loss of about 41 mils a day. A similar thing was done in Australia in 2015, and they said 38 mils a day. So we can see that it's been going on for some time, and it really does add up. So for every 100 mil of blood withdrawn, we think there's a decrease of 7 grams in hemoglobin. And of course, if we reduce that anemia, we reduce the need for blood transfusion. We've looked at this, or I say they have, at Flinders Medical Centre in South Australia in 2018. And the information is on the Australian blood.gov United website.
Thanks, Rachel. That's really quite a large volume of blood loss. I was quite amazed at that. Now, Rachel, can you continue on and tell us what strategies we can put in place to reduce the risk of iatrogenic anemia?
Yes, and we've looked at this, and lots of people have looked at this. So what we thought is, there's so much to say, Claire and I are going to share this. So I'll start and she'll finish. So the first point really is to take or not take unnecessary samples. But that does need input, because agreeing what is an unnecessary sample might take a bit of a committee. But there are things that perhaps you can look at that don't need repeating all the time. When samples are taken, It's really important to take them correctly. So obviously using positive patient identification. We are transfusion practitioners after all, and that is our mantra. Making sure we've got the right tube, making sure we've got the right volume, making sure we've got the right method. That way we seriously reduce the risk of the sample being rejected. And then we don't have to take another sample. The patient doesn't have to be rebled. We really don't want to put samples in the, we would call it the bin or the trash, just because we can't use them. And we're all really busy. And if we're pushed, mistakes do happen. So it's just that sort of taking the time and attention. And we don't want to rebleed anybody, but children really don't like it. Neither do adults, actually. Another good idea is to cluster your tests together. So you're only bleeding the patient at that one time. And if the patient has a central line, you can think about the amount of what we would call discard. So that's the amount of blood that we might take out before we start filling the sample bottles. The transfusion practitioner in your organization can really look at what would be deemed a minimal discard volume, and perhaps they could be reduced. I've looked at this myself, and there's not always standardization across the areas. Another area that transfusion practitioners look at is the use of small volume phlebotomy tubes. Now, these are tubes that have very thick walls, so they require less volume within them. This is different from a pediatric sample that might require a change in the way that the analyzer holds the sample. These are adult-sized tubes, but with a smaller volume inside them. And in Australia, One Health Service reported, I think that was Flinders again, they've been very busy, a significant reduction, 21% in volume blood loss due to blood sampling discard after bringing in these smaller volume tubes. So we know that they do work well. It's always, though, important to check with all your scientific colleagues in the laboratory, because the analyzers do really dictate which samples we use. And again, your transfusion practitioner is perfectly placed to work between the clinical area and the lab to work this out. And now Claire's going to tell us some more.
Thanks, Rachel. Yes, there's even more. So back to discards. Closed inline sampling devices are used to reduce the volume of blood discards from indwelling lines, from central lines. Closed inline sampling devices are associated with a 50% reduction in diagnostic blood loss. There are many different models available on the market should your organization wish to explore this option. Other options include non-invasive techniques to monitor blood gas or using point-of-care devices, although we do acknowledge these strategies are expensive to purchase and maintain. Low cost is frequent evaluation of routine blood orders is another area for improvement. Literature recommends that health services employ rationalization of blood sampling to minimize the volume of blood drawn depending on the individual patient's clinical needs. One example is refrain from using pre-packaged orders by Mayboom and Richards et al. And this is in Transfusion Medicine Reviews from 2017. Another example is the Canadian Choosing Wisely initiative called Pause the Draws. And the Choosing Wisely website has a toolkit which may be helpful when considering this strategy. That's choosingwiselycanada.org. And look for toolkit Pause the Draws. A simple low-cost strategy is charting the cumulative daily phlebotomy loss to help increase awareness of the total blood volume taken from patients each day. If you would like to find out more about these strategies, I suggest having a look at the Australian Blood Matters Patient Blood Management webpage, as they have a document called Reducing Iatrogenic Blood Loss Guiding Principles, which outlines strategies and key points to consider. Definitely worth having a look. And that's on the Health Victoria government website. Please contact us if you want the details.
Thanks, Rachel and Claire. Excuse me. In the introduction, we mentioned single unit transfusion was also a strategy that could support PBM. So Jana, could you describe to the listeners what this is?
Yes, thanks, Lindy. Single unit transfusion refers to a standard dosing scheme of 1 unit of red blood cells platelets or plasma in the stable, non-bleeding patient, followed by an assessment of the patient. So education and engagement may lead to an increase in single unit transfusion, as may regular audits and a computerized physician order entry, or with easier words, the electronic order by the clinician. So important to know is that the transfusion practitioner is uniquely placed to drive and monitor initiatives like this, because they engage with both clinical colleagues who make the decision to transfuse, and they also work with the scientific staff in the laboratory promoting the single unit transfusion policy. We have talked about audits before, and this is in fact a perfect tool a TP can use to measure changes in practice. It's not only important to collect data once you have implemented single unit transfusion policy, but it's also very important to do it as a baseline measurement. And of course, you have to think very well how to organize your feedback to the clinicians and the nurses so they are well informed about it. And the results should also be presented in an understandable way to the transfusion committee, the PBM committee, or any equivalent in your hospital. And when doing so, underlining the outcomes and any areas for improvement is very important. In addition to reducing unnecessary transfusions, it contributes to reducing the risk of reactions such as transfusion-associated circulatory overload, and single unit transfusion policy might also reduce costs. There are a number of tools and posters that have been developed internationally that our listeners could access.
Thanks, Jana. That leads nicely into our next question. So, Louise, how would a transfusion practitioner provide education about iatrogenic anemia and single unit transfusion?
TPs provide education in a variety of ways. And if you listen to our last podcast, number 5, it highlights different ways that TPs are involved with education. They will use tools and resources that have either been developed in-house or that are publicly available. And there are many to choose from. I'm all for not reinventing the wheel. The Canadian Choosing Wisely program is one I refer to often. Resources includes a toolbox of goodies and the pause of draws as mentioned earlier. The Canadians also have a program called On Track, and they have a toolkit guide for PBM, which is more focused on anemia assessment. There's also the Australian Blood Matters document called Reducing Iatrogenic Blood Loss Guiding Principles. Another example is a small volumes tube case study, which was published by the Australian National Blood Authority, along with a number of posters about single unit transfusions.
Okay, thanks, Louise. And again, leading into the next and our last question. So Claire, could you take this one for me, please? So where could the listeners find more resources and learn more?
So thanks, Lindley. So many countries share information about patient blood management, which listeners can access to learn more about PBM. We have already mentioned a few, such as Canadian Choosing Wisely and the On Track programs, and the Australian Blood Matters program and the Australian National Blood Authority. We also want to draw our listeners' attention to the ISBT web pages, and they have excellent information about patient blood management. So on the ISBT website, isbtweb.org, select Clinical Transfusion Working Party page and search for PBM resources. Also, if listeners have any further questions, they can contact us through the ISBT office.
Great, thanks everyone. So thank you all for sharing your time and experiences with us. We've learnt that patient blood management is an evidence-based, integrated, multidisciplinary approach to effectively manage and conserve the patient's own blood, thus reducing the unnecessary exposure to transfusion. The transfusion practitioner has an important role in PBM, as we've heard today. They can be involved in many aspects. We've also learnt that there are some reasonably simple strategies that could make a difference without any large financial investment to improve patient outcomes. Thanks so much to the listeners for joining us today. If you have any feedback, please use the questions that are linked with the podcast. If you have any further questions, you can link with us by visiting the ISBT website and checking out the Clinical Transfusion Working Party, where you'll find more details about the transfusion practitioner subgroup. We look forward to having you join us on our next episode, where we're going to be highlighting PBM programs that are in place in different countries. And this will give you an idea of how they can work. So until then, thanks for listening. Bye for now.